This is Selma Schimmel, and you are looking live at the great city of Chicago, which is once again playing host to the American Society of Clinical Oncology, ASCO. This is ASCO's 49th annual meeting, and this year's theme could not be more appropriate: Building Bridges to Conquer Cancer. More than 30,000 of the world's foremost cancer specialists are here, and so is the Group Room, making our 15th appearance at ASCO and one of our very best. Joining me now is Dr. Clifford Hudis, the president of ASCO, the 2013 to 2014 term. Dr. Hudis is also chief of the Breast Cancer Medicine Service at Memorial Sloan-Kettering in New York City. Hello, Dr. Hudis.
Hi.
Thanks for making time.
It's a pleasure.
This growing area of immunology and cancer. For many of us, the concept is it's so simple in our minds. It should be so easy to achieve, and yet it is challenging. And I think I got to interview some physicians today, and there was the Melanoma Study, but could you expand on that and also help us understand where the challenges are in our efforts to move it forward?
I agree that one of the very big science stories coming out of this year's meeting is the clear demonstration now that we can productively manipulate our immune systems to influence the course of cancer. And this has been, as you point out, a dream for a long time. Now, the problem with the dream is it was really quite simple. People imagined that getting cancer represented an immune deficiency of some sort, and then they imagined that if they just ramped up their immune system, revved it up, stimulated it, that things would get better. It often catches people off guard when you point out that many diseases represent overactive immune systems, or at least components of it. That the immune system isn't one thing. It's sort of like talking about transportation. I live in New York City. Is transportation a subway, a bus, a car, private taxi? Is it a bridge, a tunnel? Is it an airplane or a railroad? They are all transportation. But the way in which you move crowds and manage the flow of goods and services varies and depends upon which component of that system you use. So the immune system is even more complex than what I just described. So that, of course, means that we can't talk about simply turning on the immune system. Now, last year, what we heard for the first time was that we could give an antibody that, in simple terms, took the brakes off of one component of the immune system. And in melanoma, this was associated with improved outcomes. The story this year at ASCO is that that was not a one-off or a fluke. There are multiple drugs now that manipulate components of the immune system, allowing them to, in some cases, react or overreact to normal stimuli. And there's an important study showing a combination of these immunotherapies leading to really unprecedented outcomes in a heretofore pretty difficult to treat disease, melanoma. I think this is going to be important not just for melanoma, but it holds really great promise for a variety of recalcitrant diseases.
Why has it been so challenging for a concept that seems so simple? What are the barriers to success?
Well, I think the short answer is the concept may be simple, but the science is anything but simple. And finding drugs that were able to safely and productively manipulate the immune system in living people without unacceptable side effects, this has been, I think, a long, long challenge.
And I understand this is not short-term survival curves. It's significant in what we're seeing with melanoma. If we're able now to see the advance in lung cancer, potentially ovarian cancer, what does it look like as far as the evolution before we could actually realize the dream of immunology coming to the forefront of cancer care?
I think it's really, you're asking a really subtle question, because up until this meeting, the last couple of years or longer, what have we largely spoken about? Understanding the genome, understanding the abnormal signaling pathways in cancer cells, targeting those pathways with narrow precision drugs, and seeing big benefits. We have some of those at this meeting as well. But now when we talk about immunology and immunotherapy for cancer, in a way, we're going back to a broader one-size-fits-all approach. If we block CTLA-4, can we treat 5, 10 different cancers? if we block PD-1 or PD-L1, can we treat a whole bunch of cancers? Are there biomarkers within those tumor types or across tumor types that will identify better and not so great responders? All of these are questions I think to be worked out.
I have been intrigued as I've learned more about metastatic disease, where a compound may work on some of the metastases, but yet the patient still has remaining tumors that aren't responding. And what I have learned is that cancers continue to mutate, and that as we do more analysis of a patient's tissue, we may be able to further tailor therapy to understand the combinations of drugs for these tumors that are ongoing, continuing to mutate. Can you explain to us a little bit more about how this works in advanced disease?
Well, there are many models that may accurately describe some or all of the natural history of cancer. One model that you're describing is kind of the bacterial model. It's the infectious disease approach to cancer therapeutics. And what it posits is that you have your tumor, it's exposed to drug, and under the pressure of that drug killing cancer cells, only the ones that are resistant to that drug grow out. And the reason they're resistant is that one of them once acquired some genetic defect or alteration that lends resistance. Or it was there from the beginning, but it was one among a billion cells. And as you kill the cells that are sensitive, that population can grow out, the one that's resistant. The question really, though, I think has to be in part how accurate that model is across all tumor types. For example, we have some tumors that are treated with a single drug with a narrow focus, and lots of patients seem to stay in remission a long time. That challenges that model. Another issue I think that we can bring in is that it's not only the tumor, that the host has some permissive or restrictive effect, and we may be able to manipulate that. Frankly, the discussion we've been having about the immune system falls more into the latter camp. We become a little less focused on the mutational changes in the tumor when we're using the normal functioning immune components to kill it.
Thank you, Dr. Clifford Hudis, President of ASCO, Chief of the Breast Cancer Medicine Service at Memorial Sloan-Kettering in New York City.
Thanks very much.